Before we begin, I would just like to say that group psychotherapy has always held a special place in my heart, since I truly believe that we therapists don't do enough with our clients. This means we help clients make sense of the world, differentiate reality, and educate our clients until we're blue in the face. However, we might fall short in providing situations and encounters to apply such theories, and perhaps disprove some of our clients' maladaptive belief systems. It is quite a spectacular, rare opportunity that we get to allow our clients to experience a new possible reality for themselves. Admittedly, I concede that my first of 3 group psychotherapy courses was a rough start, since the younger me didn't quite understand the many benefits of group psychotherapy and what it had to offer. It wasn't until I was able to get the same experience as our clients receive regularly from this format that I became inspired and motivated towards developing this therapy to common weekly practice at Change Talk LLC. Instead of offering a list of cognitive reasons why group therapy is a wonderful clinical option for people, I would like to paint a broader picture and offer a brief parable that might envelop the usefulness of group psychotherapy, which includes the story of the long spoons. Despite there being both Hindu and Judaic versions of these stories, the easiest version to understand goes, one day a man said to God, God, I would like to know what heaven and hell are like. God showed the man 2 doors. Inside the first one, in the middle of the room, was a large round table with a large pot of vegetable stew. It smelt delicious and made the man's mouth water. But the people sitting around the table were thin and sickly. They appeared to be famished. They were holding spoons with very long handles, and each found it possible to reach into the pot of stew and take a spoonful, but because the handle was larger than their arms, they could not get the spoons back into their mouths. The man shuddered at the sight of their misery and suffering. God said, You have seen hell. Behind the second door, the room appeared exactly the same. There was the large round table with the large pot of wonderful vegetable stew that made the man's mouth water again. The people had the same long-handled spoons, but they were all nourished and plump, laughing and talking. The man said, I don't understand. God smiled. It's simple, he said. Love only requires one skill. These people learned early on to share the food with one another, while the greedy only think of themselves. So, when it comes to that spoons parable perspective, in a lot of ways, we as a society can either be a great contributor or hindrance to each other's psychological wellness. This is especially true given the overall importance of attachment patterns that span an entire lifetime. During this presentation, we will offer a brief group proposal for a psychoeducational trauma and recovery group where we will discuss the following: definition of trauma, the rationale of the group construction, group design, group inclusion criteria, leader expectations, ethical and legal considerations, topics of exploration, goals and objectives, and of course the groups, right? Beginning group stage, which is meetings 1 through 4, working group stage, meetings 5 through 9, closing group stage, meetings 11 and 12, and the Christian worldview applications. Although trauma in and of itself cannot be described in such limited constraints, trauma is best defined through a confluence of factors such as critical life events, trauma exposure, and/or symptoms of post-traumatic stress disorder. Critical life event is defined as an event in life that requires major adjustment and adaptive behavior. Trauma is best defined as any disturbing experience that results in significant fear, helplessness, disassociation, confusion, or other disruptive feelings. PTSD is best described as when an individual lives through or witnesses an event in which he or she believes that there is a threat to life or physical integrity and safety and experiences fear, terror, or helplessness. There are also many long-term consequences of both acute and chronic trauma exposure that includes emotional dysregulation in the brainstem, sensory motor activity deficiencies, sleep disorders, appetite problems, emotional regulation problems in the limbic system, attachment problems, inability to affiliate with others, mood disorders, diminished pleasure, cognition, language, and reasoning deficiencies, and developmental stage retardation. The purpose of this presentation is to expand on concepts that were learned during EDCO 711, Advanced Group Therapy, and to apply skills and knowledge assimilated in this course. This demonstration will highlight the background of trauma and the many manifestations such exposure can lead to, such as comorbid and co-occurring symptomatology. This will lead into a 12-week psychoeducational group plan for said populations and associated therapeutic interventions. This 12-week program appears from my experience to be the expected treatment frequency associated with many state and federal agencies and/or court institutions. Many individuals who have experienced a traumatic event in their lives typically have difficulty with emotional regulation, safety, and social skills. Group psychotherapy encourages group members to learn important communication and social skills, along with, hopefully, appropriate application towards regulating emotions, safety, and overall communicative processes. The group design will consist of adults 18 to 63 years of age. This group will exclude sexual trauma survivors due to the group consisting of both men and women. The group will meet once per week for an hour and will consist of a check-in and check-out activity. The group will be reimbursed through insurance and our members choosing not to utilize insurance and will pay a cash rate. It should be noted that I believe groups might be more effective if we could change the geographical and physical locations that include more activities such as hiking and camping. Unfortunately, insurance companies have a great deal of control governing the location and practice of psychotherapy groups, hence insurance managed care. The group will last a total of 12 weeks and consequently will be a closed group consisting of recurring members only for group cohesiveness. Maximum group size will be 12 participants, with a group not being held if there's less than 3 people. Groups will consist of activities and exercises that will promote participation and group discussion. The group design will include media in the form of short videos that will be less than 15 minutes. It will be utilized in order to increase clients' focused attention, portray complex concepts, and as a form of modeling intervention. Groups will be located at Change Talk LLC, located in Essex, Connecticut, where 13 chairs will be provided in a rectangular formation due to the room size constraints. The space will have 32-inch television with broadband internet for psychoeducational videos. Groups will be held Tuesdays at 7 p.m. to ensure most individuals can make their group with educational and work time constraints. Ironically, performing up to 6 groups per week, I quickly discovered Friday nights to be most laden with either excused and/or unexcused absences. In my opinion, the best therapist is first one that encourages group member return, and secondary is business savvy enough to stay in business. All right, let's talk about some inclusionary criteria. There's going to be a pre-screening that will be conducted that will include the following criteria. Members must be available for 12 consecutive weeks. Must be screened for both homicidal or suicidal ideations. Must voluntarily admit oneself to the group. Must have reliable transportation to make it to the meetings. And agree to the limits of confidentiality considerations and commit to the group confidentiality. Furthermore, and this is usually discussed in a group, I usually tell members that even though relapse is permitted, obviously you can't show up to the group with mind-altering substances. All right, let's talk about some leader expectations. Group leaders will utilize a democratic leadership style, which will promote group member input and participation. The facilitator will also remind group members regularly of limits of confidentiality inside of the group, along with consequences that will be incurred for violation of group rules. Clinician will show up to each group at least 5 minutes early and will be prepared for the group. The leader will utilize applicable activities, interventions, topics, and materials for maximum therapeutic benefit. The facilitator will not force group participation and will allow members to temporarily leave the group for less than 10 minutes. Clinician will be psychologically present and will be supportive of all member contributions. Now, this is perhaps the hardest concept to convey to perhaps new clinicians seeing this demonstration for the first time. It's okay and is encouraged by me to allow the group to deviate from their group syllabus. Remember, we have to allow group members to dictate their own treatment, invest in their own recovery, and discover the many positive realities of making calculated risks in their lives. This means if a group is performing, or perhaps something horrible or even outstanding happened to another member of the group, just go with it. This even includes members of a group asking their facilitator to alter the syllabus slightly. Again, an ethical clinician will continually remind themselves that their group is about them and not us. So let's talk about some ethical and legal considerations. Let's talk about informed consent. Participants will be informed of the nature of the theological or religious group interaction. Participants of all monotheistic benevolent faith systems will be welcome to the group. Illicit, controlled, and substances of potential abuse will not be permitted on Change Talk LLC property. Group members will be discouraged to engage with each other outside of the group during group involvement. Additional considerations include confidentiality. Members will continuously acknowledge risks to confidentiality and will promise each member that group information will remain within the group. This includes personal information, group identification information, and feelings expressed inside of the group. Limits of confidentiality will be acknowledged and agreed to. Members of the group will not physically harm themselves or another person inside of the group. When it comes to topics of exploration, these topics will include, but aren't limited to, the etiology of trauma, which some topics include causes of developmental and shock trauma, peritraumatic disassociation, and best practices. When it comes to substance misuse, we're going to talk about its background, relapse prevention strategies, and support groups. For anxiety reduction, we'll talk about anger management, self-control strategies, and sleep hygiene. And for relationships, communication skills, nonverbal communication, and crisis aversion. All right, on to some goals and objectives. Continually reinforce the differences and similarities between complex trauma and shock trauma exposures. Have group members assimilate the importance of secure attachment. Encourage group members to explore principles of peritraumatic disassociation in their lives. Recognize how self-esteem, along with PERMA interventions, affect self-worth and general well-being. And will demonstrate the difference between self-esteem and self-compassion. We will also assimilate stress reduction techniques, such as forest bathing, deep breathing, and general exercise. We'll discuss sleep hygiene best practices that will include blue and orange light exposure, ways to reduce body temperature before bedtime, which affects sleep, and white noise machines. Also, we'll identify ways of feeling safer at home, which could be getting a cheap security system for as little as $10 a month, placing bottles in front of your doors to make some noise when somebody opens up the door, or emotional support animals. With that out of the way, on to the preliminary outline for the 12 psychotherapy group sessions. In the beginning group stage, we're going to allow group members to identify themselves, build rapport and group cohesion. Apprehension and safety concerns may be experienced early in these associated groups, and typically groups during this stage require consistent structure and high levels of direction by the group leader. In the beginning stage of the group, we're going to welcome group members, explain to the group how groups may be beneficial, provide the purpose of the psychoeducational group, which includes differentiating the difference between development and shock trauma, teaching skills for better sleep, better anxiety, and reduction in post-traumatic stress disorder, encouraging PERMA interventions to combat feelings of both disassociation and depressed mood, and discussing co-occurring diagnoses and its role with trauma survivors, and of course, group individual introductions. And through rounds, each participant will state their first name and what they expect to obtain from their time inside of the group. We will also discuss group rules and expectations, which includes attendance, the 12-week commitment, discuss how rules are subject to change depending on the needs of the group. We're going to provide an overview of confidentiality and its limitations. We're going to discuss the importance of confidentiality. We're going to explain the difficulties associated with ensuring confidentiality in group formats. And then, of course, we're going to close the session by asking each group member's reaction to today's group and a critical incident they experienced during the group. As for meeting 2, we're going to conduct a group check-in, remind the group of the previous week's group highlights, provide group feedback on current rules and expectations, and then we're going to define complex and post-traumatic stress disorder. We're going to discuss similarities and differences between PTSD and CPTSD. One of the things I like to do with groups is getting them used to having a small audience, which is typically why I push for triads rather than dyads. Triads consist of a small group where they discuss one critical incident in their lives that may be considered traumatic. The rounds will consist of what PTSD symptoms does each group member believe they have, and then allow group members time for reactions and individual group member goals being discussed for the next week, and of course closing the group. All right, for meeting 3, we're going to again have a check-in process, allow an overview of last week's group, discuss as a group belief systems that either reinforce or marginalize traumatic events, and discuss as a group how their faith has sustained them during times of great difficulty. We're also going to promote conversations surrounding last week's triad experience. We're going to discuss the universality of suffering and pain, the ethnocentrism of how culture affects our overall beliefs, and also we're going to discuss in greater detail the effects of stress and anxiety along with associated physiological symptoms, and of course closing the session.
You have nightmares? Every soldier has nightmares. Only one who is ashamed of what he has done. You have no idea what I have done.
All right, I often like to use Tom Cruise in The Last Samurai as an example of how a dominating cultural influence can alleviate PTSD symptoms. After watching this video, the group will discuss how cultural and belief systems either reinforce or marginalize critical incidents, have each group member identify their own rationale of why we suffer, discuss world theological applications to war, death, and physical suffering, and the group as a whole, do individuals that are born with physical disabilities suffer more than individuals that sustain them after birth? I like using that question surrounding physical disabilities to assist my efforts towards explaining how points of reference can help either define a life situation as being either traumatic or challenging. For meeting 4, we're also going to allow group members to discuss at least one goal they have for the upcoming week. We're going to ask the group for impactful statements associated with today's discussion. Any emotional member reservations, conflict, or multicultural issues will be addressed. And of course, we're going to close the session. All right, for the working group stage, we're going to encourage participants to be more socially relaxed and candid with the group. We're going to increase group cohesion and commitment. Individual group members will be confronted and encouraged to participate more as a group, along with the leader attempting to become less directive. And the group leader adapts a tawa of poo, or going with the flow ideology, and expresses their intention for group empowerment. Meeting 5 will consist of a group check-in process, provide a brief overview of materials that was discussed during the last group, ask group members to identify any tangible progress that they're currently seeing in the group, and encourage group members to practice I statements, utilizing weasel spectrum language, and attending behaviors. Meeting 5 will consist of triads, where they will break into 4 unique groups with members that have yet to be with them. We'll attempt to find social media images or a brief video that helps define their own culture. And of course, we'll complete a round activity where there'll be a discussion that associates grounding interactions in personal space, aka focusing on nonverbal behaviors. We'll allow time for group discussion, and of course, we'll close the group. Meeting 6, the clinician will open up the group and have a check-in activity. The leader will discuss an overview of highlights surrounding the last group activity. Group members will utilize the entire group discussing themes of existentialism and religion. Groups will discuss the following themes during meeting 6: the meaning of suffering, freedom to choose, and death being a motivator towards accomplishing some of our goals. And then, of course, closing the session. All right, meeting 7. We're going to ask group members to open up the group with an acceptable prayer or mantra that helps them keep going. Conduct weekly check-ins. Discuss the positive benefits associated with religion, and asking group members to identify any exceptions to their current problems. We'll also discuss the stages of change, or also known as the trans-theoretical method. Explain the difference between the following: a visitor, complainant, consumer, which is the solutions-focused brief therapy model of change, and then, of course, closing the session. In meeting 8, we're going to conduct weekly check-in processes again. We're going to discuss various substances of abuse, explain how trauma or inherited trauma may cause predispositions for individuals to abuse substances, and as a group, discuss various behaviors and substances that may help individuals disassociate. We're also going to explain to the group how several pharmacological methods towards treating trauma may inhibit trauma processing, discuss the benefits of prazosin and risperidone, which may be beneficial for intrusive PTSD symptoms, discuss the difference between physical and psychological pain, and of course, close the group. Meeting 9, we're going to ask group members to check in with the group, just like always. We're going to discuss with group members repressed versus suppressed memories. We're going to explain the difference between declarative and non-declarative memories. We're also going to discuss bilateral stimulation and its importance in memory processing, explain the purpose of sleep and with rapid eye movement stage of sleep, and we're going to close the session. Meeting 10, we're going to conduct another check-in. We'll discuss to the group the various modalities of psychotherapy to assist trauma survivors that include prolonged exposure therapy, cognitive processing therapy, and eye movement desensitization and reprocessing. We'll also discuss the importance of extra therapeutic factors associated with trauma recovery. We'll explain to the group that it's not just about reduction in symptoms, but replacing that negativity with something constructive. And of course, close the session. All right, finally the closing stage, where outside continuing resources are explored with group members. Members are reminded of the transient nature of the group. Clients that wish to continue treatment are offered both peer support and clinical options, such as psychotherapy. Meeting 11 will consist of a check-in activity that includes the homework assignment, discover outside continuation of PTSD support and treatment. Members are provided both with local peer support options and engagement therapeutic activities. And the leader discusses the creating a crisis and safety plans. Members will also discuss their safety crisis plan and how it can be beneficial to them. The group will also discuss how next week it will be their last meeting together and any thoughts, feelings, or reservations surrounding such a transition, and closing the session. All right, with the end being near, the group members will conduct their final check-in, where they'll discuss with each other their overall progression towards their initial goals over the lifespan of the group. Each member will discuss at least one recreational support or clinical option for continuing their recovery. Members will also share their crisis safety plan that they created and what they will do with it if their symptoms become unmanageable. The group will check out with each other and give supportive feedback to each group member. The group will conduct a Worrystone mindfulness activity, and finally, the group will terminate successfully. Just some quick thoughts surrounding adding religion to psychoeducational groups. Despite this psychoeducational group having the choice between spirituality and religious affiliations integration, future Christian-led groups may offer the following benefits: tackling spiritual crises such as, why did God not protect me? Acknowledging malevolent forces, use of religious scripture for guidance, healing nature of prayer, and groups consisting of similar culture and belief systems, which might feel more inclusive. All right, everyone. I want to thank you all for making it this far into my presentation. If there are any questions, please feel free to provide them in the comments section of this course and/or the YouTube sections. As always, God bless, and I look forward to our next assignment together.